start. So kia ora koutou. Again, welcome to Mobile Health Evening Seminar, webinar, and welcome back for all of those of you who come in regularly. I'm Pauline Proud, I'm in Auckland. This is the Manukau Harbour behind me, and your speaker tonight is Harriet Sims, who's also based in Auckland. Now, Harriet is a registered nurse and clinical team leader at Tupu Ora Community, and that's the Auckland Regional Eating Disorder Service. Harriet's a registered nurse and a clinical team leader at Tupu Ora, and for the past 10 years she's been working with young people, adults and their families to support them with physical and mental health challenges. Harriet has experience in providing medical and psychological treatments for eating disorders, along with experienced treatment for general mental health. So welcome, Harriet. Thank you.
Thanks, Pauline. Good evening, everyone. It's really exciting to be here. Really passionate about getting the message around eating disorders out far and wide. So looking forward to this evening. So I'm just going to jump in. The focus of the presentation tonight will look at kind of more widely at eating disorders first, and then a bit more specifically about the treatment in young people. So I'm going to try and explain where we think eating disorders come from and how we diagnose them. Then think a little bit about assessment and how we monitor people who might be presenting with an eating disorder. And then, as I said, specifically about young people. So I always like to start with the common misconceptions in social context that eating disorders occur within. So these are some of the really common myths that come up regularly, and you probably have heard them in day-to-day life. So one of the places I always like to start with this presentation is demystifying some of them. So a common one that's been around for a long time is that eating disorders are a lifestyle choice and not a serious illness. The idea that someone kind of chooses to have an eating disorder and that the focus of it is around looks and vanity, maybe the model aesthetic. And we know that eating disorders are actually a really incredibly serious mental illness that people don't choose to have. And another one, particularly in young people, that's a myth that often comes up is that parents are to blame, or something that's happening in the home is to blame. And we know that sometimes the family context could have contributed or be playing into what's happening, but it's not the cause of an eating disorder. And parents are actually usually our most important resource for someone getting well. Other really common one, dieting is a normal part of life. And I often get a few arguments around this one because dieting is just so prolific, particularly in the Western world. And it's just not actually a normal thing that humans need to do. So we are really anti-diet as such. In eating disorder work. And then the last one, that it only affects white middle-class females, particularly adolescent girls. And the research is really clear around this, that it affects people from all ethnicities in all parts of the world and presents in mostly the same rates throughout the world as well. So it's a really, it's not a societally bound illness as such. It's present everywhere. So thinking about the social context that people are living within around eating habits and the diet messaging. So most commonly we see most people at some point in their lives will have tried a diet or done some kind of alternative eating habits. And that can be actually anything from veganism to fasting to just some calorie counting, some cutting out a food group. It'd be pretty hard pressed to find somebody in New Zealand who hasn't had a go at that at some point. And that's kind of one end of the scale. As we start to be concerned about whether that's maybe tipping over into an eating disorder, we're thinking about, is it interfering in the person's life or affecting their health? And that might be the point where we're starting to raise some red flags and be concerned. And then right at the other end, the more kind of extreme end, is someone meeting full diagnostic criteria for an eating disorder. to consider as well. Plays a big part into eating disorders and can be quite culturally driven as well. So understanding that it's part of our self-image and how we view ourselves and what we think our appearance might say about us. So there's often a lot of judgments, and this can be different in different cultures around what certain parts of the body might mean. So a higher weight might represent laziness, a lower weight, something to achieve and be kind of put up on a pedestal. And we know that struggles with body image affects most people. So in this research is a little bit old now, but it just shows that thoughts about body image and worries about people's bodies affects most people. And it's getting younger and younger. And so always one of the most concerning statistics in this study was the 1 in 4 7-year-old girls having tried to lose weight at least once. So these messages are coming into people's worlds at a really, really young age. So one of the theories that we work with in eating disorders is the body positivity movement, and trying to move the judgments out of weight and size, really, and knowing that the more research that has been done around weight and what that means in terms of someone's health, the less those two things can be matched together instantly. So if I look at someone and see them as a higher weight, that doesn't necessarily tell me anything about their state of health. Same at a lower weight. So there's the real extremes that we see of the really, really low BMIs and weight and the really, really high ones. There's likely to be some health issues going on, but everything in between doesn't necessarily tell us much about someone's health status. And my favourite, most important message of all is that diets do not work in the long term. And so really what we want is that we're getting to people earlier in their changes to food. So whether it's that they're starting to go into more of a binge pattern or starting to go into a restrictive pattern, before people have drastically changed their BMI, we want them to start to get some really good information and education that dieting in either extreme is not effective, and it's going to lead to more issues with weight as time goes on. So, what causes an eating disorder? There's lots, like many mental illnesses, lots that we don't know. But it's starting to become more and more clear that it's very complex, and there's a multitude of triggers and risk factors that make up an eating disorder. So I'll go into this a bit more. So some of the biological things we know is having a close relative with an eating disorder or a serious mental illness. So for example, in some of the genome sequencing that's being done, anorexia sits in a similar sequence to psychosis and bipolar. So if someone else in the family has a mental illness like that, then it's going to raise the risk for a person. Do see it more prominently in people with the female sex, and around the onset of puberty, into probably kind of late teens is the most common time things starting. Any sudden weight loss, that's often a catalyst. So most commonly people will describe either an intentional or non-intentional period of weight loss right before the onset of an anorexia. And people also have a high risk of anorexia with type 1 diabetes. There's kind of two main personality profiles if we were kind of categorizing things. So in anorexia we tend to see more perfectionism, anxiety, OCD type behaviours, and in bulimia or binge eating, we tend to see more difficulties with processing emotion and tolerating distress, more chaotic type personalities. Sports, really kind of high achieving young people can be a risk, and we see a high prevalence of trauma, PTSD as a comorbid presentation in all eating disorders. Then kind of being in a society idealise, right? And that can kind of add to the risk factors. Anyone in our rainbow communities at higher risk, and particularly people in our gender diverse communities, are seeing more and more. Not that it's kind of more prevalent, but just that people are accessing help more easily at the moment. And some kind of change in someone's environment. So whether that be like moving countries or moving schools, changes in the family structure, those kinds of things can impact as well. So we know more and more about how the brain plays into this, and this is particularly relevant to anorexia. And we often end up focusing on this a lot because of the high medical risk that comes with anorexia, although it's probably the less prevalent of the eating disorders in your kind of average community. But there's some of the things that's important to think about in terms of anorexia and what you might hear about as a change in a person that's happening. As I said, tend to be more obsessive compulsive traits, anxious temperaments, perfectionistic, avoidant of emotions or difficulties kind of tolerating negative emotions, quite rigid, difficulties with change, and a reduced reward sensitivity. And it's really common for people to report that starvation has a more euphoric feeling to it. So you often hear people talk about the idea of being hangry when you haven't eaten, and that's how the general population would feel. But someone who maybe has a tendency or has a risk factor for anorexia might get more of a euphoric feeling from starvation. And that can kind of then start to link into a bit of an addictive cycle for restriction. So again, in terms of anorexia, we learned a lot about the medical risks and the way someone might present from the Minnesota study that was done in the 40s and 50s, and was very unethical. You not get away with doing it now. But at the time, they took 36 young soldiers just post the war, and they wanted to understand what happened when somebody was starved. And so what was seen when the men were starved was very similar symptoms to what we see in anorexia. And probably the difference is when people were re-fed, the people who had the risk factors for anorexia, some of those cognitions and difficulties stayed and took longer to resolve, whereas people who weren't at risk of anorexia, all of the symptoms resolved on weight restoration. So we know that low weight has a really incredible effect on the brain and the body, that's shutting a whole lot of things down. And so one of the most important first things with anorexia is to re-feed someone, and a lot of the symptoms will disappear over that time. So thinking about the diagnoses, I'm going to talk particularly, so most services in New Zealand will treat, specialist services will treat anorexia, bulimia, and some will treat ARFID, and occasionally binge eating. There's kind of a current tension that the DHBs are still working on the DSM-4 for diagnosis, of which ARFID and binge eating aren't in. They're in the DSM-5. So it's a bit of a grey zone as to whether services are treating those two diagnoses at the moment. So I'm just going to focus on the three that we're primarily treating. So for anorexia, we're looking for restricted intake that puts someone at a body weight and developmental stage that's less than where we think they should be at, or less than what their normal is. An intense fear of gaining weight, a disturbance in the way they see their body, and then we think about the two subtypes. So one subtype is restricting, and the other is binge purge. So this can often get confused with bulimia, but if someone's got low weight and they're losing losing weight as well as engaging in binge purge cycles, then that would be anorexia. If they're at a weight that would be considered healthy for their body, or at a higher weight and is binging and purging, that's more likely to be bulimia. Although we take BMI into consideration, we know it's really evident that people can develop anorexia at any weight. If they've had a fast and significant degree of weight loss that has triggered off the cognitions around fear of gaining weight, and disturbances in the way they see their body, then you can develop anorexia at any weight. So it's a little bit old school now to think about the categorizing by BMI. And while that's still relevant, it's just really important to consider that someone could be developing anorexia at any weight. So that's generally referred to as atypical anorexia if it's someone that would be considered in the BMI range as at a normal weight. And so, like I say, the difference with bulimia is that someone would be more in what would be considered a healthy weight for their body, and they haven't had any weight loss, or they're not actively losing weight. With bulimia, we tend to more just see some weight fluctuations, but within quite a narrow zone. So we're looking for periods of eating that would be considered more in one session than what you'd consider an average person having, and generally them describing a lack of control over that. So it's really important when we start assessing for that to get an idea of the amounts of food quite specifically. And then they're engaging in some kind of compensatory behaviour to try and prevent weight gain. And it's helpful to think more widely than just purging with that. So people could be doing that through exercise or through laxative use or some other way of trying to get rid of that food. Concerns about weight and shape, but usually not as intense as in anorexia. And then in terms of thinking about severity, we think about how often these episodes are happening in the week and how sort of interfering in life they are, or how much effect they're having on the body physically. And then ARFID is one we're seeing more and more when there's been a medical complication from it. So I guess ARFID would have historically been known as the traditional picky eater, or beige eater, which for a lot of kids is really normal, and that's a phase that they grow out of. So when we're thinking about it as a concern that might require treatment, we're looking for when there's significant weight loss or nutritional deficiency, which has stopped development in its tracks usually. So it's really key that there's no concerns about availability of food, or there's no active attempts at weight loss, concerns about weight or shape. It's just more purely focused on a difficulty with getting enough nutrition in. And often the young people we're seeing with this, that's become incredibly narrow, their intake. So it could be one brand of chicken nugget and one brand of biscuit, and that's it. And that's the kind of level of challenge we're getting into. Okay. Assessment. So quite a wide variety of things to think about when you're seeing someone, to just consider in the back of your mind, maybe could an eating disorder or disordered eating be involved with this? So commonly it can be other people around the person who start to notice concerns and raise concerns. With young people, there's some really common times that they present more in bulk. So it's often Christmas holidays when family who haven't seen them for a while see them and notice that they've lost weight. Coming back after school holidays, teachers might notice that. If you're in a clinic, maybe you haven't seen them for a couple of months and then you see them. So often immediate family are some of the last to pick it up because they're seeing them day to day and they don't notice the weight loss as acutely as people who see them less frequently. In children and adolescents, any kind of weight loss or just static, not growing in height, so anything kind of out of the normal developmental trajectory. Any acute events, so commonly people are dehydrated, there's electrolyte disturbances, hypoglycemia. It's very common that people present with other gastrointestinal issues. A loss of menstruation or kind of irregular menses is really common. So these are things that could occur for a multitude of reasons, and it can just be useful to check in around eating as part of them. An over-focus on healthy eating or some kind of change into particular diets, restricting particular food groups, that's new. Excessive exercise, that can be one of the really difficult ones to treat. So noticing if a young person's getting over-focused on exercise, and particularly outside of the team environment. So if it's that, say they're rowing, but they're also, 5 times a week, but now they're also going for a run every morning on their own and doing something else. So it's kind of going above and beyond what the team would be doing. It's really common for eating disorders to come up in people with diabetes, particularly young people with diabetes, chronic bowel issues, thyroid issues, and weight loss due to an acute illness. So it's a very common way that young people present is having had some kind of infection or gastrobug or something like that, and really struggled to regain some weight afterwards, and they've had then all the other risk factors for an eating disorder, and that's what may have kicked things off into an irregular eating pattern. And pretty much everyone we see presents with something else too. So the other one that's not on that list that's really common is PTSD as well. So as is commonly part of a comprehensive mental health assessment, checking in on people's food and eating and exercise, and trying to establish if that's is disturbed as part of whatever else is going on for them. So in the UK, some screening questions were developed particularly to help people in primary healthcare, as a way of asking just some actually really direct questions as part of a consultation, and then using those to gauge whether